session is about, as a workshop, we'll learn about the burden of traumatic brain injury among correctional populations and approaches to practices when you encounter someone with a TBI. Using problem-based group learning, you will explore case studies and develop your own action plan to work with the case you're presented with. Here are the bios, and I want to welcome our guests. First person is Flora Matheson, and she is a research scientist with the Center of Research in Inner City Health, St. Michael's Hospital. She is also the assistant professor with the Dalla Lana School of Public Health, the University of Toronto, and adjunct scientist with the Institute of Clinical Evaluation Sciences. Next person is Catherine McIsaac. Is a social epidemiologist and postdoctoral fellow with the Center for Research on Inner City Health at St. Michael's Hospital. And there's Kate Moore. Is the manager of the Toronto West Clinical Services at CODA. She is also the Community of Practice Lead for ABI at CODA. Kate has worked in the field of ABI for the past 15 years. And the last person, Pam Merritt, joined CODA in 2009 to help develop and manage their new ACT team as part of the MHCC's at-home Chez Soi demonstration project on Housing First. She is now a senior manager at CODA, and she received her MSW from Master University right here in Hamilton, where I've worked. So I'd like for you to welcome our speakers.
Great. Thanks so much for that introduction. Can everyone hear me okay? Okay. So today we're going to be talking about traumatic brain injury in prison populations. And our workshop really has four main components. First, I'm going to be walking you through some of the scientific literature about traumatic brain injury in general and about traumatic brain injury in correctional situations. And then I'm going to be passing the floor over to my colleagues, Pam Merritt and Kate Moore, and they're going to be talking about some of the symptoms that we commonly see among people that have a traumatic brain injury or TBI. And then we're going to turn it over to Flora, who's going to moderate some Q&A for us. And then we're going to put the floor over to you guys and give you guys a few scenarios, and then through problem-based learning, you guys are hopefully going to work through some situations where you recognize individuals with traumatic brain injury. So to that end, I'm going to start. So what is traumatic brain injury? So traumatic brain injury has been defined as a disruption in the normal functions of the brain caused by some sort of an external force. So that can be either a blow to the head, a jolt to the head, or some sort of a penetrating head injury. So although the mechanisms for a traumatic brain injury are the same, the results and the consequences of TBI can really vary quite a bit. It can be a very mild injury characterized by really no long-term consequences, or it could be something that's a bit more severe, and something that has very severe short-term consequences and very severe long-term disability-related consequences. So, looking at longer-term consequences of traumatic brain injury, this here is a figure that shows the distribution of people, or the number of people in 4 different regions that are living with a traumatic brain injury-related disability. So we have the EU, the USA, Canada, and Australia. We can see that in the European Union, the number of people who are living with a traumatic brain injury-related disability is actually quite high. It's about 7.7 million people. And the number declines as we move from the European Union to the US, to Canada, and to Australia. But of course, as you guys might be thinking, the EU obviously has the largest population, and Australia has the smallest population. So once we normalize for something like population size, we get a measure called prevalence. And the prevalence of TBI-related disability in each of these regions is about 2%. So about 2% of people in each of these populations are living with a traumatic brain injury-related disability. So you can imagine that it can be quite costly to have a traumatic brain injury. So a study that was published in 2012 looked at the costs of traumatic brain injury in the Ontario healthcare system in the very first year after injury. So they found that individuals who had sustained a traumatic brain injury had about, it was a cost about $32,000 to care for that person in the first year after that injury. And that care was just hospital-related utilization, healthcare utilization costs. So that would include something something like the immediate hospital visit after you get a traumatic brain injury, following up with your physician, and rehabilitation costs. That's about $32,000 for the average patient in the first year after injury. But traumatic brain injury is not uncommon, and so when we look at the number of people in the population in Ontario that actually have a traumatic brain injury, the costs really can accumulate. And it was estimated that in 2008 and 2009, the costs for traumatic brain injury in the healthcare system was $121 million in Ontario alone. But of course, it's not just the healthcare costs that we have to worry about. Individuals that sustain a traumatic brain injury, they may not be able to contribute to the workforce, and they may be requiring social assistance, and all these other things that really the costs can accumulate. So when we think about the indirect costs of traumatic brain injury, it actually amounts to quite a bit more. And it was estimated that in Ontario, the indirect costs of traumatic brain injury are about $1 billion, and in Canada, about $3 billion. So that's quite a bit of costs associated with traumatic brain injury each year. So who gets a traumatic brain injury? So if we think about risk profiles for individuals with and without a TBI, so there's several socio-demographic and health-related risk factors associated with an increased propensity for sustaining a traumatic brain injury or TBI. So age is a strong risk factor for TBI, and the relationship is like a U-shape. So individuals who are at the youngest age of the end of the age spectrum and individuals who are at the oldest age spectrum are really more likely to sustain a TBI than individuals in the middle range, so like a U-shape. Also, individuals, the propensity for traumatic brain injury varies by an individual's sex or gender. So research suggests that men are at least 3 times more likely to get a traumatic brain injury than women. Other risk factors include ethnicity and race. So in Canada, people of Aboriginal or Indigenous identity are actually more likely to be injured in general and are more likely to have sustained a traumatic brain injury than white people. And then in terms of place, we know that rural people are more likely, individuals that live in rural regions are more likely to experience a traumatic brain injury. And that can be related to things like occupation, so farmers may be more likely to sustain a TBI, or it could be just related to the types of activities individuals living in rural environments engage in. So for example, they may be more likely to ride around in an ATV, and that may increase their propensity for a head injury. So all these socio-demographic things are risk factors for a traumatic brain injury. But there's also health-related consequences or health-related things that really increase your likelihood of sustaining a TBI. So mental illness is one of the big things. So individuals that have mental illness, in particular, things like schizophrenia, really increase your propensity for having a traumatic brain injury, and individuals that use substances and abuse substances. And you can imagine how that would play out. Taking drugs or alcohol could increase your risk of falling or violent activities, and all these things may increase your risk of sustaining a TBI. So what happens when you get a traumatic brain injury? So once you get a traumatic brain injury, research in more recent years tends to suggest that people with a traumatic brain injury are actually at an increased risk of incarceration. So there's been 4 studies in recent years that have been really large and looking at basically everybody in the population. And these studies have been performed in Australia, New Zealand, Finland, and Sweden. And they've come to the overwhelming consensus. Even though these are really diverse countries and diverse settings, the consensus is that people that have a traumatic brain injury are just way more likely to have some sort of involvement with the criminal justice system at a later date than individuals who have not sustained a traumatic brain injury. And so the estimates suggest anywhere from about a 1.5 times increased risk for individuals that have sustained a traumatic brain injury to about a 3 times greater risk. And this increased risk is really corroborated by evidence from meta-analyses. So meta-analyses are really studies of studies. So what they do is they combine results from individual studies to get a more robust and powerful estimate of something like the burden of TBI in incarcerated populations. So these first three things in the table are meta-analyses that were conducted in adult populations, youth populations, and a combination of both youth and adult populations. And the N refers to the number of studies that were really combined in order to generate these estimates. So we can see from the first three studies that the prevalence of traumatic brain injury, so that means that the proportion of people in prison that report having a TBI range anywhere from about 40% to 60%. And this very last estimate from Colantonio, so she is a colleague of ours at the Toronto Rehab Institute, and she estimated that in Ontario prisons, so this is specific to two Ontario prisons, that about 40% of individuals who are incarcerated or who were incarcerated had a traumatic brain injury. So that's in Ontario. And once individuals who are incarcerated once individuals who have a TBI are incarcerated, there's also evidence to suggest that they don't adjust as well to the prison environments. So an American study that was published in 2010 found that both men and women who went into prison with a traumatic brain injury were actually way more likely to engage in behavioral infractions and get charged with prison misconduct than individuals who had not sustained a traumatic brain injury. So in men, the risk was about 2 times greater, and in women, it was about 1.5 times greater. So just to emphasize, these are everybody that is incarcerated, but just comparing individuals who had a traumatic brain injury to those that don't have a traumatic brain injury. So traumatic brain injury, once you're incarcerated, these individuals look maybe a bit different than individuals without a traumatic brain injury that are incarcerated. So if we just look at men who are involved in the criminal justice system and that have a TBI, they're actually more likely to report a history of drug abuse or alcohol abuse. And these are data coming from Ontario. And it's not just like they're more likely to report a history of drug or alcohol abuse and initiate this drug or alcohol abuse at an earlier age, but they're more likely to be exposed to family histories of substance abuse. So individuals who are incarcerated with TBI, they look a bit different than other individuals who are incarcerated without a TBI. So this is in men, more likely to report histories of substance use. And then if we look at women who are incarcerated with a traumatic brain injury, one thing that was noted in this Ontario-based study is that they're way more likely to report having a history of trauma. So this trauma is characterized by physical abuse and by sexual abuse histories. So it's not just like the TBI is something that we need to be concerned with. In women, it's traumatic brain injury and these other clusters of things that really go together with the TBI. So moving on to some of my last few slides. So what are we thinking? Do people really know about traumatic brain injury in prison? And among people that are incarcerated that have sustained a traumatic brain injury, many of them have actually not sought medical attention for their traumatic brain injury. So in Canada, it's been estimated that anywhere from 16 to 18%. And this is really shocking and almost egregious if you think about it, because we have a publicly funded healthcare system. And so about almost 1 in 5 or 1 in 6 individuals with a traumatic brain injury have not sought medical attention. And of course, this number is much higher in the United States where they don't have universal health care. So amongst people that have sustained a TBI, there's not really the awareness that this could potentially be a problem. And then in the research community in Canada, one of our colleagues, Fiona Kuyumjin, led an analysis looking at where the gaps are in prison research in Canada. And she found that there's actually, in spite of the fact that TBI is quite common in criminal justice populations, there's actually been only 3 studies in the Canadian context that have looked at traumatic brain injury and how it impacts Canadians who are incarcerated. And then amongst correctional healthcare staff, there's been a consensus that they're not really clear on how this should be, they don't actually feel very comfortable in engaging with and treating individuals that have had a traumatic brain injury, and they have misconceptions about what traumatic brain injury is and what some of the common symptoms that are experienced amongst individuals that have had a traumatic brain injury. And then finally, because traumatic brain injury is such a problem in prison populations, or it really seems to be quite prevalent, we should be screening for TBI in prison populations. This is not necessarily universal. So in some U.S. states, there is a routine screening for traumatic brain injury. So for example, in South Carolina, they use the Ohio State instrument, which we're going to be getting to later on. And in Minnesota, they have a really interesting initiative looking at traumatic brain injuries, and they've developed a questionnaire to look at the burden of traumatic brain injury in correctional facilities. And then Correctional Service of Canada, they do screen for traumatic brain injury, but they don't use an extensive screening instrument. They just ask about lifetime burden or lifetime exposure to traumatic brain injury. So on that note, I'm going to pass the microphone on to Kate.
My name is Kate Moore, and I work for CODA. And CODA is an organization that works in the community to support individuals with mental health and cognitive challenges to live well within their communities. We offer a wide range of services to adults living with serious mental illness, geriatric mental health conditions, acquired brain injuries, and developmental disabilities and dual diagnoses. Our services include case management, supportive housing, short-term residential beds, day programs, court, and justice-related services. I'll be describing the signs and symptoms of traumatic brain injury and provide some strategies to support people with a few specific cognitive deficits and behavioral challenges. Pam will introduce a screening tool that helps to determine if the person you're working with is likely to have a history of TBI. Then we'll walk you through 2 case scenarios, and we'll break into small groups for you to answer a few questions. Then we'll be coming back together as a large group to gather your findings and summarize our learnings. TBI can result in significant cognitive, behavioral, physical, and emotional changes in an individual, and no 2 TBIs are the same effect on an individual. TBI is often referred to as an invisible disability because there may be no obvious outward signs of disability, and the symptoms may be seen as other illnesses or character traits, such as speech and motor effects can be misconstrued as somebody being intoxicated. People may be seen as having angry characteristics when they have difficulty regulating their emotions, and a lot of signs of ABI or TBI can also be referred to or seen as mental illnesses as well. The first area that I'm going to talk about is memory, and memory is one of the most common cognitive deficits, and memory that happens when somebody has a TBI. Memory is when the brain takes in, stores, recalls, and uses information, and a brain injury can affect any of these areas of memory. There's 3 steps of memory that can be affected. So people may be affected at the encoding stage, and that's where the brain is able to interpret information and create proper coding to be stored into the brain. So somebody that has a challenge in this area might have difficulty being able to store any information that you're trying to share with them. The second area is storage, so the brain's ability to store and retain information. And somebody that has challenges with storage in their memory would be someone you would have a conversation with, and then 10 minutes later you're having the same conversation like it hadn't happened before. So that might be someone who's experiences challenges with storing information. And the last stage that can be affected as well is retrieval, so being able to find and recall information that's been stored. And we all can experience this at times, the tip of the tongue phenomenon where you feel like you know the information but you can't find it. People with TBI can experience this at a greater degree. It can be very frustrating, or they may not be able to find the information at all, even though it has been stored. If you're working with somebody that has a memory impairment, it's really important to assist them in introducing memory aids or assistive devices to work in place of their memory. If their memory isn't functioning properly, it's important to help teach someone to use tools that will help them take the place of their memory. So a lot of times, people working with individuals with TBI will use written or verbal reminders. If the person isn't likely to remember an event, they'll find a way for the person to have a written or verbal reminder so that they can take the place of that memory. Setting alarms for important tasks, for example, meds. So you can help the person to set an alarm on a cell phone, on a watch to alert them to when their medication times are. We use this a lot in serving people with TBI to help them maintain their medication programs. Blister packs are also helpful for people that have challenges with remembering their medication because it's separated out into various sections so you can remember what medications you've taken and what medications you've used. Developing routines is very important in terms of helping people with memory impairment because procedural memory is the kind of memory you have where you do something automatically that you've done over and over again. So if you drive to work every day the same route, sometimes you might drive to work and realize that you got there without having to think through the steps. And that means it's been encoded in your procedural memory. And that's something we try to help our clients that have challenges with TBI to learn because that's often intact. So practicing and repetition are really important in developing routines, can help a person to try to encode something that they're having trouble remembering the actual steps for. And the use of a calendar, planner, or smartphone to track important appointments. These are really important tools for people with a TBI, and it's really important to help the person pick an item of the type of memory that they find most useful, because then they're more likely to use it. So a lot of our clients that may be homeless or marginally housed, it's more helpful for them to have a small pocket calendar from the dollar store that's not costly, that they can carry around. People, it won't be easily identifiable or stigmatizing for the individual. And some people really prefer to be engaged in technology, so using smartphones, there's many apps for reminders, even just the calendar in Outlook is helpful for people with TBI and memory loss. The second area I'll be talking about is attention. So signs that someone may have an attention deficit is the person may have problems with staying on task. The person may have a lack of retention of information once you explain something to them. They may become easily distracted, or they may appear confused. And attention is the ability to focus on a task or a thought. It allows us to multitask and focus on important information. There are three types of attention that can be affected. Selective attention is the ability to quickly sort through incoming information and stay focused on one thing in spite of distractions. So right now you're using selective attention to pay attention to what I'm talking about, even though there may be sounds from the back of the room, lights flickering, other noises. You're able to block those out most of the time and pay attention to what's happening here. You're using selective attention. Sustained attention is being able to stay focused on a task for a period of time. So if you're reading a chapter in a book and you read the chapter from start to finish, that would be an example of sustained attention. And divided attention is the ability to multitask. So driving a car can be is divided attention because you're dividing your attention between the road, your speed, what's happening in the rearview mirror, and you're going back and forth between all of those things. And attention deficits can sometimes be confused with other issues. So sometimes people believe that someone has a memory problem because they're not remembering anything, when it may actually be an attention deficit. And it can also be seen as defiance or stubborn behavior, because someone that has difficulty focusing their attention because of their TBI may not be able to sit for long periods of time, become more agitated, or look like they're not listening or not caring about what you're saying. The strategies to support people with attention deficits are pretty straightforward and basic, but it's really important to decrease external external distractions. So if you're trying to talk to someone about something really important and they have difficulty paying attention, you want to take them somewhere that's quiet, where people won't be interrupting. If you're in their home, you're turning off the TV to talk to them about things, anything that could be a distraction you're looking to remove. It's really important to avoid fatigue, as this worsens attention problems. So you want to give frequent breaks and meeting with people at certain times of day where they're less likely to be fatigued. So in the morning, related to things that are very important. And the third step is really helpful, is having the individual repeat back important information to check that they understood and that they may retain the information. Because attention is really the first stage of memory. If you can't attend to something and pay attention, you won't be able to learn it. But if you can help the person to actually pay attention and they're able to repeat back what's happening, they're more likely to remember. I'll also be talking about behavioral changes. So people with TBI are likely to experience changes in their behavior, and many family members of people with TBI report that the individual isn't the same person they once were. And some of the following behavior changes can occur with TBI. So a person may express a lack of empathy, they may be rigid and inflexible in their thinking, they may lack initiative or motivation or seem apathetic. They may use poor judgment or disinhibitive behavior. They may have impulsive behavior, or they may become more aggressive. Aggressive behavior is more likely to occur after a brain injury due to frontal lobe damage that can affect a person's ability to control their behaviors and their emotions. Our frontal lobes act as our filter and our emotional braking system. Some individuals with brain injury may experience a lack of control over their anger and find themselves acting out more readily. A person may have an extreme reaction when they feel themselves getting angry, and some individuals with a TBI may go from 0 to 60 in an argument or a disagreement. They may be more likely to engage in verbal or physical outbursts such as yelling, screaming, punching walls, or becoming physically aggressive. And this can be particularly challenging for people that are already involved in the justice system, as they can continue to run into problems. The strategies to support individuals with aggressive behavior are also somewhat straightforward. So if a person has a TBI and they're becoming aggressive, they're yelling, screaming, physically acting out, it's really important immediately to give the person space to calm, if at all possible. I know it sounds basic, but I think when we're in the situation, we're trying to talk the person through it. And really, a person that has lost you can't rationalize with someone who's lost their ability to rationalize. Any of us who lose it, and time to calm down and regain that control. And that's one of the first steps that's really important that we sometimes forget. So giving a person space and time, less people talking to them, the better, to be able to regain that control. For someone with a TBI, it will take them a bit longer, likely, to be able to regain that control. So you'd be checking with them to see if they're able to talk after. Once the person is calm, it's really important to offer feedback after the event that happened. And because they may have memory challenges, you want to make sure that you talk to them as close to the incident as possible while still giving them time to calm. It's helpful to help them identify possible triggers to what happened. So you'll be wanting to pay attention to what happened right before they got angry. That can help you and the individual identify what does trigger their anger or their aggressive outbursts, so that they can work to avoid those triggers or manage them when they find themselves in those situations. It's also helpful to identify signs of anger with individuals. We all have signs of anger, and working with our clients, we'll often try to engage with them about what they feel just before they became angry. So some people can hear their pulse in their ears, some people feel their face getting hot. We'd be asking the person what they felt before it happened, and then developing with them what can they do the next time they start to feel that way, because they may not be able to to stop it beforehand, but once they feel that way, they can know, I'm angry, and then develop a plan to either leave or stop a conversation, or just before they act. And then there's also support groups for anger management and behavior therapy in the community for people with acquired brain injury that can also help people with TBI. Another area that can be affected by TBI is impulsive behavior and disinhibition. So a person with a TBI may engage in impulsive behavior or experience disinhibition where they're reacting quickly without stopping to think about the consequences and saying exactly what they're thinking without filtering their thoughts. Again, that can be related to frontal lobe damage. So our frontal lobes do act as a filter for us so that everything we think doesn't come right out, but that can happen for people with traumatic brain injury. They may be lacking that, and it can be very challenging for the individual. Impulsive behavior can be anything. So had a lot of clients that have impulsively been engaging in theft, stealing things when they see something, they take it without thinking. Unsafe behavior like walking out into the street without looking because they impulsively saw something they wanted to do. And it can be very challenging to support someone in the community that has this challenge. Some of the strategies to assist someone with these problems is to give feedback about their behavior immediately in the moment. So if someone says something very inappropriate or very unsettling, it's important to give feedback about that. Or if they're about to engage in something that's risky, you want to give feedback immediately. It's really helpful to help the person problem solve and talk through potential problems. So if you know you have a client who may impulsively grab items when they're at the store, before you go to a store with them, you're going to want to talk to them about it. So I know this has been a challenge in the past. You're talking them through it, helping them problem solve and identify what might happen and what might occur so they can be more successful in that outing or in the activity they're engaged in. And you can also involve behavior therapists in treatment of these behaviors as well, which are available in the community as well. Next, Pam Meir is going to speak about the TBI screener.
Thank you, Kate. Hello. Can everybody hear me okay? Okay. So I'm going to be telling you about a screening tool, an easy screening tool that you for TBI. It just takes a couple of minutes to complete. It's a structured interview that asks an individual about their lifetime history of head injury, brain injury. The screener is recommended for use by professionals who are working in the social services and healthcare fields. It's an assessment tool that helps us gather history and interpret the findings, but it's not a diagnostic tool. It's important to remember that we're not able to diagnose unless you're a physician or a psychologist. They're the only ones who would be qualified to make that diagnosis. So on this slide, I just am showing you, it's a tutorial, it's online, that is really useful. I found it really helpful how to use this screener. It includes videos where they're interviewing individuals and they walk you through the entire process. And we have a link to that website in our presentation. So as Kate mentioned, TBI has been called an invisible disability, which can impact a person's ability to cope with stress or adapt to new situations. It can also affect their ability to respond to your services or treatment. The person may not even realize that they've had an injury in their life. We're going to talk more about that. So by using the screener, you're asking the questions that allows a person to talk about their history of injuries. This is the screening tool, and it's got 3 steps across the top. And I'm going to use my fancy pointer just to help us with this a little bit. So there's step 1, everyone should have a copy, a hard copy of the screener that's been completed at your table. You can use that to follow along as I talk about the interview process. Some of you have screener 1 or scenario 1, and others have something that's called scenario 2. Don't worry about those scenarios right now. We'll tell you more about that later. But right now, I'd like you just to look at this so I can give you a basic overview of the screening tool itself. Starting with step 1, you're going to ask the 5 questions that are on the left-hand side of the page. So these questions are intended to help the person recall any past injuries to their head or neck. You're going to check off yes or no to each of the questions based on their answer. If they say no to all 5 of the questions, then you can stop the interview at that point after step 1, and you can assume that there's no TBI. But if they answer yes to any or all of the 5 questions, then you're going to be recording the cause of each injury separately in the column in the middle of the page under step 1. And I'm going to point to that. So here. So you ask the 5 questions, and then writing down the cause of each injury that they're telling you about in that space. If you need more room because the person has identified a number of injuries, you'll find on the back of the interview screener that there's more space to write under step 1. So in step 2, you're probing and you're getting more details about each of those injuries that the person identified and told you about in step 1. So you're asking what their age was at the time of injury, if there was a loss of consciousness, and if so, how long that lasted, and or if they were dazed or had a memory gap. These might have resulted from contact sports, like hockey or football. Could also happen from physical fights, being physically abused, or being in military duty. These are just some of the examples that could lead to a TBI. So I have an example to show you the steps 1 and 2 here. So I'll just, again, use the pointer. And tell me if you can hear me while I'm talking. Is it okay? Okay, so for this individual, they fell off their bike. They reported telling me that they fell off their bike at age 9, and there was no loss of consciousness, but they did report being dazed or having a memory gap. And then at age 14, they were in a car accident, and they reported having a loss of consciousness that lasted in a period of 30 minutes to 24 hours. And then when at age 19 and 20, they were in Iraq, when they were around explosions, and there was no loss of consciousness, but they were had memory gap when they were dazed. Okay, so in step 3, we're now looking beyond the steps 1 and 2. We're now looking at something else. We're asking about person's history of any repeated blows to the head that they may not have even realized were injuries. These again might have been caused by contact sports and so forth. So the repeated blows to the head. And again, we're going to go back to our example to look at what occurred to that person in step 3, that we uncovered in step 3. Again, we were talking about the Iraq explosions. They had multiple blows to the head between the ages of 19 and 20, impacts to the head that had not caused them to have a loss of consciousness, but they did experience, that's the most severe effect, being dazed or having that memory loss, memory gap. And now we're going to go to the last step, which is step 4, interpreting the results. If you look on the back of the screener tool on the right-hand side, you'll see a checklist, and you'll use this checklist after you've completed the screener interview with the individual. If you're able to answer yes to any one of these items on the checklist, then the person is more likely to have experienced a TBI and be experiencing ongoing problems. So the questions that you're asking yourself as you go through that checklist is, did the person report at least one severe or moderate TBI? Did it occur before age 15? Did they have 2 or more TBIs close together? Did it happen recently? And have there been other significant events that caused brain impairment, such as a stroke or a drug overdose? So though we can't diagnose a TBI, we can use the information that we gather from the screener to help us adjust our approach when working with the individual. So I'm going to finish here with the TBI resources. That includes that website with the tutorial. There's also referral information on here. I'm going to turn it over to Flora now. Thank you very much.
Okay, so we have a few minutes for questions. So you can roll up the room for questions for anybody on the panel. Okay.
Can you speak to the criteria for diagnosis of TBI? I'm just wondering about individuals who have repeated head injuries. Like I'm thinking in terms of youth that I work with that are head bangers. And sometimes that goes on for a long period of time. They may not lose consciousness. They may not have complaints of being dazed or memory loss, but I gotta think that some damage is being done.
I think it's really challenging to, for the medical professionals to be able to diagnose mild TBI, which that may occur in. They can do CT scans or MRIs to try to find damage on the brain, but those tools aren't always, they see big things, but they don't see little things. So I think the purpose of introducing the screener is to say, maybe this person does have a brain injury. There's also, people can do neuropsychological assessments to find any of the cognitive challenges they may be having. So even though they can't see it with an MRI, they can see the cognitive deficits the person has and possibly diagnose them as well. So those are the 2 routes you can take to try to get a diagnosis for an individual.
Other questions? Yes.
I was wondering if you could speak a little bit to the risk factors, especially in relation to being Aboriginal. Why is that a risk factor?
Well, I think just in terms of, I think it's probably related to things like where you're living, rural environment. I mean, I don't want to say for sure, but I can speculate maybe rural environment. And so, for example, if they experience a head trauma and they're not able to seek medical attention right away, so some of the Indigenous communities are remote and isolated, and so that might exacerbate head injuries if you're not getting rehabilitation early. But that's not in terms of risk factors. And I also think it's just maybe in terms of lifestyles. If we think about things like substance use, so substance use is associated with an increased risk of traumatic brain injury, and we know, unfortunately, that Indigenous persons in Canada tend to disproportionately use substances. So does that answer your question?
Yeah, I'm wondering about environmental factors, like would you say that poverty and things like that, substandard living is associated with those risk factors?
Well, sure. I mean, we know that the housing conditions in a lot of First Nations communities in Canada are substandard, and maybe just having a poor house could contribute to traumatic brain injury and incidents of traumatic brain injury. Those are great points. Yeah, I think definitely the environment.
There's another question.
You, in the beginning, had made a comment about individuals that are incarcerated, they look different. What do you mean by that, with the TBI? I'm not following you.
Sure. So I guess the point is that individuals who are incarcerated that have a traumatic brain injury, there's evidence to suggest that they also have a lot of other things that are clustering together. So things like substance use or mental illness. And we've already established, or I had established on earlier slides, that these are real risk factors for traumatic brain injury. And so when they're in jail, it's not just the TBI that could be potentially preventing them from really adjusting well to the prison environment, but also these other things that are happening with the TBI. So it's not like we should just be treating the TBI, but also looking for other things that are maybe common in people that have TBI. Does that answer your question?
It does, like, it just leads to another question. So once we have a screener that says they have a TBI and they're incarcerated, what are our Ontario jails doing to accommodate individuals that have the TBI?
That's an excellent question, and I do not work in the Ontario jails, and none of us do. Yeah.
I think it's an area that's still being developed in that area. We have a team that works out of the Toronto South Detention Center, and I think that those clients would often be seen under the mental health umbrella in the jail. I don't know that there's TBI related support yet in the justice system, but it might be something that they'd be looking for.
Is there anybody in the audience that would want to add to that discussion?
Yeah, we have 14 system navigators across the province for brain injury. And in some areas of the province, they have made inroads into the facilities. And myself, I'm a navigator for Northeastern Ontario. And I work with the Regional Justice Committee in that. But we don't have a formal program yet. We do a lot of cross-education in that, but in other areas of the province, and I think you'll hear some of those presentations over the next 2 days, they do have a program.
I just want to say that in Hamilton, we have a acquired brain injury corrections working group. And our Veronica, who is the ABI coordinator in our area, navigator in our area. So if you're really interested in learning about what we're doing in terms of discharge planning from the correction center, Barb over there is my co-presenter. And we're doing that Wednesday morning.
There's also Omer from the London area that's done some justice work as well in that area.
Thank you. Thank you. Maybe one more question? Yes.
I was just wondering about, when you're talking about strategies for working with individuals, one of the biggest things I'm coming across is vulnerability of other people. They do this to look out or whatever, and they're getting charged while the other person walks free. I'm just wondering, do you have strategies that you use? Do you talk to those other people that you find, couch surfing at that person's, what do you find helpful to do to minimize that vulnerability?
So I know that on our ABI case management team, we have a number of clients that are very vulnerable to the influence of others. And I think what we try to do with those individuals is to work with them on problem solving, helping them think through the consequences to their actions, and teaching them kind of safety skills in terms of managing their relationships with other people as best you can. And it can be challenging because people are so isolated that the people that are drawn to them may be taking advantage of them, but I think that those are the things that you can try to do to support them. And role play. So on one of our teams, we were working on role playing situations with the client, and it really did help because the client can maybe say, "Oh, I won't do this for this person," and you walk out the door and they do it, or "I won't open my door to people once you leave, but you go knock on the door and they open the door." So sometimes role playing can help with the person if they're comfortable.
Sorry, I didn't hear that.
I said, and if that doesn't work, use court diversion.
Yeah. Once they're in the system. Yeah.
Great, thank you. I'm going to turn you back over to Pam and Kate. I just wanted to make one little announcement, or just to let you know that Katie and I have a collaborative relationship with Correctional Service Canada, and we're doing some work. We've linked correctional data with medical data at the Institute of Clinical Evaluative Sciences, and we're in the process of developing that analysis. So if anyone's interested, please give us your name, and we'll keep you up to date on what's happening with that.